Yeah. Good evening, everyone. Today is the last live session of the knee MRI course. This is one of a kind course which was conceptualized and conducted by OrthoTV in collaboration with InnoVision. And to continue with this, so that I hope most of you have liked it and enjoyed the course as much as we have while conducting it. So I would like to just share my screen and show you what is next, what is coming next. Tell me if you can see my screen.
Yes, sir.
So the next is this. We are coming up with a shoulder MRI course, which will be again conducted by Dr. Aditya Daftari, Dr. Malini Lavande, and Dr. Ankita Ahuja from InnoVision. And it will be, instead of 4 weeks, this time it will be a 6 weeks focus certificate course, which will start next month in October 2022. The dates will be announced. We will be sharing the link first with this group who have completed the new knee MRI course as soon as the course is over. Before we share this, we also would like you to fill up a feedback form to get the certificate at the end of this course. With this, I hand over to Malini. Malini, you can take over.
Yeah. Thank you, Neeraj. Yeah.
Yes.
So I think we've already shared 4 cases with you. So I hope you've gone through that. And what we'll do is discuss those 4 cases today. And meanwhile, I would also request all of you to put your questions in the chat box because we can answer them. Those questions may relate to these 4 cases or may not be related. Anything related to knee, you can put your questions up meanwhile so that I can answer that after we discuss these questions. I'll just share my screen and we start with the first case. Yeah. So is my screen visible?
Yes.
Yeah. So when we look at knee MRI, we always follow a particular sequence. The first sequence I would like to look at is always the fat saturated sequence. It is usually sagittal in our protocol, but it could be coronal. Different centers may do a little differently. That's okay. But basically, we are looking at a fat sat T2. And why is that? Because normal marrow in adults has fat, which is bright on T2. And almost all the pathologies are bright on T2 because they are in some way related to edema. Now, bright fat, bright edema, you cannot differentiate. So we make the fat look very dark. So then whatever remains bright is what is abnormal. So now this scan, I'm starting looking at it. It's from medial to lateral. I can see some subcutaneous edema. As I come to the medial meniscus, this here is the body of the medial meniscus. And I can see intrasubstance signal within it. Here it's not reaching the articular surface. But what is more catching my eye is this marrow edema in the tibia. Now, if we look at the cartilage, can you identify this cartilage defect out here? There's this one small area where the arrow is pointing from here to here. There is a full thickness cartilage defect. If I zoom it up, this black line is the cortex. This gray is the intermediate signal intensity hyaline cartilage. Here there is a full thickness cartilage defect. But when I look at the tibia, the cartilage doesn't look so bad, but I see a lot of marrow edema. Now, what can be the cause of marrow edema is our question. It could be degenerative, but if it was degenerative, I would expect much more cartilage loss here. Also, degenerative marrow edema, there would be some marrow edema on the other side also. You would not have disproportionate marrow edema only in the tibial side. So these are odd. Could this be infection? That's another thought we are keeping in mind. Again, I wouldn't expect so disproportionate marrow edema in the tibia. And this joint effusion looks very clean, doesn't have any synovial thickening or debris. So then you notice this, and this patient has not had any trauma. That history would also be important. So then when I notice a small linear subchondral hypointensity. And that's telling me that this is likely a subchondral insufficiency fracture. But we'll look at other things now. We'll look at other sequences also. Now, this is the anterior horn of medial meniscus, posterior horn of medial meniscus. So I can see them well. But as I come medially, I don't see any posterior horn here at all. This is the anterior horn, but there's no posterior horn at all. Normally, you should see the posterior horn going all the way up to the PCL. This is the posterior cruciate ligament. Up to this section, I should have seen it, but it falls short. I don't see any medial meniscus. That makes me think of a root tear. Again, we'll come to the corneal images to confirm. Anterior cruciate ligament looks intact. Posterior cruciate ligament looks intact. This is also a good section to look at trochlear cartilage. And the medial trochlear articular cartilage does not look good. We'll come to that in the other sequences. And also look at patellar cartilage, also look at trochlear cartilage, because especially this area, you will not see it on axial images. So this is lateral, you can see the cartilage fine, but when you come medially, here you can see the cartilage is not fine. Next, coming to the lateral meniscus, this is the anterior root, this is the posterior root, and anterior and posterior horns look fine. The body looks okay. Yeah. So now let's look at the corneal images. So when I look at the corneal images, I'm coming from posterior to anterior. This here is the posterior horn of medial meniscus. And you can see here, there is a defect. Normally, this medial meniscus posterior horn should be curving and attaching to the tibia, but there's a defect. So there is a posterior root tear, a radial tear of the posterior root. And as I said, whenever we see posterior root tear, the next things we have to see immediately are the extrusion of the meniscus and the status of the cartilage to decide whether root repair will be helpful or not. So here there's quite a large root tear. When you look at the meniscus, it shows degeneration, intrasubstance signal here. And you can see there is mild extrusion. This is the line along the medial and tibial condyle and femoral condyle. And you can see there is mild extrusion. Cartilage is not bad, except for that full thickness, one cartilage loss area we saw. Tibial cartilage is fine. But this is the subchondral insufficiency fracture that we saw on the sagittal images. So look at the cartilage on these images also. They are seen as intermediate signal intensity. I look at the medial collateral ligament and I can see the entire medial collateral ligament well. I look at the fibular collateral ligament and the popliteus. They often show hyperintense signal like this, like tendinosis degeneration in most of the patients. Inner central tibial plateau lateral, there is some chondral thinning, some subchondral cystic changes. This is the lateral meniscus, and you can see its apex is a little bit blunted, but again, no real large tear or anything. Next, I look at the axial images. On axial images, look for the patellar cartilage, and you can see superior inner medial patella. You can see here, there's some cartilage thinning, but again, nothing too bad. Otherwise, patellar cartilage is well maintained. You look at the trochlear cartilage here, well, and you can see this is where there is cartilage loss, central and inner medial inferior trochlear cartilage high grade loss. So we'll call it high grade when it's more than 75% of the thickness, intermediate 50 to 75, and low grade less than 50% thickness. Then on the axial images, we look at the ACL. ACL, always remember to look for the femoral attachment on the axial images, and it is normal. This is the PCL. So you can see ACL and the PCL on the axial images. This is the posterior capsule. This is the fibular collateral ligament. You can see it going here. This is the fibular collateral ligament. This is biceps femoris. This is popliteus. This is iliotibial tract. This is the popliteal vessels. This here is the tibial nerve, and this here is the peroneal nerve. This structure here. So always look at peroneal nerve whenever there are injuries, because there is chances that that could be injured. These are your pes anserine tendons. So you may have peri-pes anserine or pes anserine bursal fluid. And always remember to trace the patellar tendon all the way up to the tibial attachment. So now I look at the sagittal PD images to confirm again. This was the full thickness cartilage defect we saw. We can give its measurement. There was root tear, mild extrusion. Otherwise, cartilage is fine, but there is subchondral insufficiency, fracture. There is inferior central and intermedial trochlear high-grade chondral loss. Lateral compartment is relatively fine. So the impression here would read degenerative posterior root tear of medial meniscus with mild extrusion of the body segment and moderate intrasubstance degeneration of rest of the posterior horn. Moderate medial tibial subchondral marrow edema with subchondral linear hyperintensity suggestive of subchondral insufficiency fracture, and the other cartilage changes what we looked at. So just how many of you agreed with all these findings, and anybody who thought anything else or any questions till now? We can always take that and then we can move on to the next case. I don't see, yeah.
Can it be labeled as a synovitis, or there was a lot of synovitis or patellofemoral effusion, I guess?
Yeah, so there is effusion, but that's another thing. So effusion often is reactive, especially when there are internal derangement, when there is recent trauma, or when there is degenerative osteoarthrosis, you get reactive joint effusion. So how do we distinguish? Let me just share the screen again so that I can share that case itself. Yeah. So what we do is when we see effusion, we have a few things we look at. Are there internal derangements? Is there cartilage loss? Is there anything else happening? Then we look at the effusion itself. Is it clear like fluid? This looks just plain bright T2. I look at it on this image. You can see on the axial image, there is no synovial thickening. You can see this. This is the thin capsule out here. There is no synovial thickening. So then, yes, there is effusion, which you will mention, but that's not the primary pathology. It is just reactive in relation to the underlying pathology. If I see synovial thickening, then I start thinking, can this be infective? Can this be inflammatory? Sometimes it can get very difficult to distinguish between the two, and we give a differential diagnosis. But we can try. If it is irregular kind of synovial thickening, then it's more likely inflammatory. If it is more smoother, then it is infective. If there are surrounding abscesses, if there is more of bone marrow erosions and all of that, infective is more likely. But as I said, it can sometimes get very difficult. If there is no internal derangement, menisci, cartilage, ligament, all completely normal, but there is effusion and not much of synovial thickening also, then we will say that effusion in the abscess, and again, it has to be significant effusion. Because one thing to remember is there is always some physiologic joint fluid. No joint is completely dry. So because of that, this is, yes, this I would call it as mild to moderate effusion, but some little joint fluid is fine. In the absence of internal derangement, an inflammatory etiology needs to be ruled out is what we could say. But here, because this patient has cartilage issues, there is subchondral insufficiency fracture as well as meniscal root tear, this effusion, I would consider it only reactive. Any other questions with respect to this case? So then we can move ahead, but also what you can do is any other questions also, because I think Aditya told me that there were questions regarding cartography or cartilage mapping. We'll take that at the end. So now also any questions that come to your mind, please feel free to put it in the chat box and we can answer later. So if there are no questions with respect to this case, we can move ahead. So again, MR helps in that way that we can say what is the cause of the pain. So in this patient, whatever the acute pain is currently is due to the subchondral insufficiency fracture, even though the patient has other findings also of cartilage as well as meniscal root tear. But the current symptoms which are there, acute pain, is because of the subchondral insufficiency fracture. Okay, we need to see popliteus and ITB in cornal view. Yes, sure. We'll do that in the next case when we take it up. We'll do that. So let's move to the next case and we'll look at the corneal images in that. Or maybe, okay, in this only, let me just finish that so that I don't forget. Yeah. So on corneal images, see, this is the popliteus muscle. You can see the popliteus tendon going up here, and this is the popliteus origin at the femoral condyle. And just superficial to that is the fibular collateral ligament or the lateral collateral ligament origin. This is the proximal portion. As you come more forward, you can see this is the mid portion, and then you can see it going down and inserting here to the fibula. So the fibular collateral ligament.
I'm not able to see the audio video.
Are you able to see now?
No, ma'am.
I have shared the screen. Is anybody else able to see the screen?
Ma'am, we are able to see the video.
We are able to see, madam.
Yeah. So, okay. So this is the lateral collateral ligament. You see the proximal portion behind. As you come more anteriorly, you can trace rest of it. So normally you don't see lateral collateral ligament in one corneal section. If you see, then that means there is something wrong with the anterior cruciate ligament, and there would be anterior cruciate ligament insufficiency in those. So let me just go to the next case. Yeah. So we're just going to the next case. Again, as I said, I always begin with the fat saturated sequence. Now here, for example, there is sagittal as well as coronal. So different people use different protocols, but any scan will have one fat sat sequence for sure. So I start looking at it. This is the medial meniscus body. You can see bright signal in the posterior body and posterior horn, but it's not reaching the articular surface. So this is not tear. This is just intrasubstance degeneration. This is not a tear. Cartilage looks intact. We need to look at the anterior, central, posterior weight bearing medial femoral condyle as well as the posterior non-weight bearing medial femoral condyle. This here is the tibia. The cartilage looks fine. I trace the medial meniscus and I can see it going all the way here where you see the PCL. It's coming till there. So that means there is no root tear. See how well you can see the trochlear cartilage and the patellar cartilage. So sagittal images help you look at that too. This is the anterior cruciate ligament, again normal. It shows some hyperintense signal and striated appearance near its tibial attachment, but that's normal because ACL has a wide attachment at the tibial attachment. And because of fat in the synovial recesses, you get a striated appearance. This is the posterior cruciate ligament, femoral attachment, mid substance, and then the tibial attachment. Again, that is normal. We'll just come to the anterior compartment later. Let's just finish the lateral meniscus. This is the anterior root. This is the posterior root of lateral meniscus. And as you come more laterally, you can see the entire normal cartilage. This is anterior horn, lateral, posterior horn of lateral meniscus, and this is the body of lateral meniscus. So this is kind of a good example to see normal ligament and cartilage. But so we'll just come back to this image. Let me, since we are on the topic of ligament and cartilage, let's look at the other ligaments too. So this here is the ACL. You can see tibial attachment, mid substance, femoral attachment. This is the PCL, femoral attachment, mid substance. This is the tibial attachment. So look carefully for any avulsion fractures at this location. Now, this is the posterior horn of lateral meniscus, posterior horn of medial meniscus. This is the popliteus tendon that we spoke about. And this is the lateral collateral ligament. You can see this. This is the femoral attachment, then comes like this, and this is the biceps femoris. They join together for the conjoined attachment. See how well this cartilage is. So again, this is the normal articular cartilage. This is normal menisci. So this is a good example to see that. This is the medial collateral ligament. You can see here normal. And as you come anteriorly, you can see the patella here. This is the non-fat sat sequence. And again, we can see the menisci, except for mild intrasubstance degeneration here. The cartilage and the ligaments and the menisci are normal. Quick look at axial images. Again, cartilage is normal. Trochlear cartilage. This is a good section to look for the depth of the trochlear groove and what morphology it is, what shape the patella is in patients with patellar instability. This is the lateral patellar retinaculum. This is the medial patellar retinaculum. So look at the vastus medialis. Wherever that ends, that is the medial patellar retinaculum. You can see in this patient, this is the patellar attachment. This is the femoral attachment. It is a bit attenuated, but we see that often. So unless there are other findings, it may not be significant. This is the medial collateral ligament. This is the anterior cruciate ligament. This is the posterior cruciate ligament. Both seen very well. This is the lateral collateral ligament, and this is the popliteus. So you can always trace it from here, and this is biceps femoris. Biceps femoris, lateral collateral ligament, both join and attach to the fibula. While the popliteus tendon, what we saw here, crosses behind and becomes the popliteus muscle. This is the capsule. You can see this, the posterior capsule. This is the semimembranosus tendon, and this is the pessancini tendon. So just coming back to this. So this patient presented with anterior pain. So what do we see? Few things. One, I see degeneration within the patellar tendon. So remember, quadriceps tendon towards its insertion can have little striated appearance, which is normal. But patellar tendon, again, right near the patellar attachment, sometimes you may see artificial signal. So always compare with the axial images that it's not artifact, it is real. So now I look at the same section on the axial images, and you can see that the signal here persists. So there is patellar tendinosis, but also what is more important is, can you see this bone fragment out here? So at the tibial tuberosity, you can see these bony fragments. So this is a PD sequence, non-fat sat. So you can see how bone seen. So this is bone here. So there is fragmentation at the tibial tuberosity with marrow edema. You can see all this bright signal, marrow edema, surrounding soft tissue edema, and tendinosis just adjoining. So all of this fit into Osgood-Schlatter disease. Many a times we may see in adults also Osgood-Schlatter disease sequel. They have had some kind of Osgood-Schlatter disease in their as when they were child, and now you just see this fragmentation without any marrow edema, without any localized pain. But here there is marrow edema. When there is marrow edema, it signifies pain there and localized pain there, suggesting Osgood-Schlatter disease. So extensor mechanism on MR, we need to look at sagittal images and corroborate the findings on the axial images. So when I look at axial image, you can see this fragment here, this bone fragment out here. There's another fragment out here, and there's a lot of it. Remember, this appearance of fragment-like can be normal in children. In developing skeleton, you can have an ossification center here, but this kind of marrow edema and soft tissue edema is always abnormal. Often in sports, people, runners, in sports with jumping, you may see jumper's knee, which is nothing but patellar tendinosis at the patellar attachment. So at this level, you may see hyperintense signal. As I said, always correlate with the axial images. So right at this level, there is not much happening on axial. So that may not be real, that can be little artifactual. If there is localized tenderness, and if on axial also you see it thickened and showing bright signal, that is suggestive of patellar tendinosis. Another problem, what happens is when there is quadriceps tendon tear, and the tendon gets retracted here. So it's important that we make a larger field of view. So normally, see, the scan is ending here. We keep a less field of view so that resolution is good. When you increase the field of view, the resolution of the image gets poorer. So it's important, if you're suspecting quadriceps tendon pathology, you need to mention it in your note so that the technician makes sure that more of this is included. So that's this tendon where it is retracted, that location can be seen so that we can give you the exact gap as to where the tendon is retracted. Another thing, when you look at quadriceps tendon, as we know, it has contribution from vastus medialis, lateralis, intermedius, and rectus femoris. So sometimes you may have a tear of only one area. So again, axial images, sagittal images, and corneal. So you can see here it is seen where this part is contributed by vastus medialis, this part is contributed by vastus lateralis, and this by vastus intermedius and rectus femoris. So you can have a tear involving only one of them. So that's also something that we need to see. And that's why placing a pain marker becomes important and useful, because when you place a pain marker, you know that is where the patient's pain is. So any questions with respect to this case? So this, the impression would be Osgood sclerosis, which is apophyseal. Also in children, you need to look at this area carefully. You can have a periosteal sleeve avulsion. So you will see a very slender, you can see this. If I show you here, yeah. Can you see this slender black line? That will be Avulsdorf. There'll be soft tissue edema, some marrow edema may be there, but this black line is what would get Avulsdorf in pediatric periosteal sleeve avulsion. So it's important to know where the pain is for us also to try to identify it better. Should we call it as partial articular tear of quadriceps at superior patella? Yeah. So, okay. No, this patient does not have, because like I said, let me just share this again. It is very common to have a bit of striated appearance at the quadriceps tendon. That is normal. So let's look at this. Yeah. So this appearance is normal. So there's no, so always look at different sequences. See on this, you may see there is some striated appearance, but when you see here, you realize that it is not retracted or anything. And as I said, having axial images here, unfortunately, axial images are not going through there, but let's look at corneal images. You can see this corneal image, this is entangled. So when we are suspecting quadriceps tendon pathology, we need to make sure we have sections going higher up. This is just fat in the synovial recesses. MPFL in this patient, yes, is attenuated, but there is no tear, but it is attenuated, that's right. So if we just look at it here, this is the vastus medialis. As I come inferiorly, this is lateral patellofemoral retinaculum. This is medial patellofemoral ligament or retinaculum. This is the patellar attachment. This is the mid substance, and this is the femoral attachment. So yes, this is attenuated, but as I said, we find this very often, and unless there are other signs of patellar instability or clinically there is patellar instability, we would not be worried too much about this. So the problem with MR is it shows quite a lot, and we need to figure out which of them is significant. Here is the Hoffa's fat pad. So this is the Hoffa's fat pad. So if you can see this slender line out here, that's the infrapatellar plica. And that, so plica is another thing. We see plica.
Always, man.
Am I the only one losing signal?
I just got disconnected from Zoom. I don't know why. Am I audible now?
Yes, ma'am.
Yeah. Okay. Okay. I'm sorry about that. Yeah. Okay. Yeah. So we were looking at Hoffa's fat pad. Yeah. So this is the Hoffa's fat pad. This thin linear structure is the infrapatellar plica. And sometimes, so you have pathologies here, like you may have edema out here or scarring out there. So somebody who's undergone arthroscopy, we just see some scarring out here. And if it's mild scarring, that's normal. Only when it is very diffuse and extensive, we'll call it as arthropfibrosis. You can get Hoffa's fat pad impingement. More often, we get lateral infrapatellar Hoffa's fat pad edema, which can be seen with friction between the patellar tendon and the lateral femoral condyle, and that suggests patellar maltracking. We may also get edema in the quadriceps fat pad. So you can see here, this is the quadriceps fat pad, this triangular structure. This is normal. You may have bright signal there. It may be swollen, and that could be quadriceps fat pad impingement. Okay, other questions? Were there any other questions? I'm sorry, because I got logged out. I can't see the earlier questions. MPFL I discussed, Hoffa's fat pad I discussed. If there was any other question, please put it on the chat because I can't see the older ones. Okay. So then we can just go ahead with the next case. Yeah, we go to the next case. Give me just a minute. I think it just logged me out of everything. Yeah, so we come to the next case. This is the third case. So the first one was root tear of the medial meniscus. Second one was Osgood-Schlatter. And now we have this third case. Okay. So we are looking at the FATSAT sequence first. And the very first thing which catches our eye, obviously, is the significant marrow edema in the anterior tibia. So one important thing is the pattern of the marrow edema. That gives us a clue as to what could be the type of injury. So for example, if we have marrow edema here in the anterior lateral femoral condyle and in the posterior lateral tibial plateau, we know that this is a pivot shift injury mechanism, and we are invariably going to find an ACL tear most likely. So you look at ACL very carefully. Associated with that, you can have medial meniscal tear or lateral meniscal tear, but primarily it's an ACL tear we are looking at. When we have marrow edema in the anterior lateral femoral condyle and in the inferior medial patella, then we are looking at a lateral patellar dislocation. So we need to look at medial patellofemoral ligament. We need to look for cartilage fragments. When we have marrow edema in the medial femoral condyle like this, you need to look carefully at the medial collateral ligament. Always remember, when you have marrow edema, look carefully for any bone fragment or subtle fractures, or also look at the overlying cartilage, because when you have active cartilage defect, active cartilage delamination, you can have marrow edema. Here, what do we see? The marrow edema is all predominantly anteriorly in the tibia. Now, marrow edema can be due to few causes. One, it could be direct impaction. Something is hitting the bone. Or it could be avulsion kind of forces. Something is pulling on the bone. Or it could be reactive to something else, like there is infection or degeneration pathology. So here, anterior, and in this patient with trauma, we know that this fits into dashboard injury. And dashboard injury, we are typically looking for posterior cruciate ligament pathology. So that's how these marrow edema patterns help us try to know which structures to look carefully. Also, the marrow edema can explain the pain and also the amount of marrow edema one may decide to operate after the marrow edema settles down. So for example, here, lateral meniscus, we start looking here. Lateral meniscus looks normal. The marrow edema we already saw. This is the anterior cruciate ligament. And again, to just reaffirm, this appearance of anterior cruciate ligament is normal, this striated appearance. Always look at the axial images. The axial images give you the clue whether ACL femoral attachment is normal or not. Because this kind of striated appearance can still be normal. It could be a low-grade injury. I'm just trying to figure out the, ACL here. So you can see this ACL femoral attachment is fine. There is only some hyperintense signal. So this would be like a low-grade injury or sprain. Nothing more than that. But then I look at the PCL. PCL normally I should see as a question mark shaped structure. Here I can see the femoral attachment. Here I can see the tibial attachment. But in between that, I don't see anything at all. So this is a high-grade mid-substance posterior cruciate ligament tear, which fits in with the dashboard injury. Now, I see something anteriorly here. This is the posterior root of lateral meniscus. This is the PCL injury. This is ACL. So what is this black thing out here? So always trace it. It goes to the posterior horn of lateral meniscus. The structure then comes all the way and goes to the femoral condyle. So now if I see this on the corneal image, you can see this. Can you see the structure here? Going from the posterior horn of the lateral meniscus, horizontal structure goes to femoral condyle. So that's the ligament of Humphrey, the meniscofemoral ligament of Humphrey. So don't confuse this for a lateral meniscal tear. Don't confuse this for some loose body or something. Trace it. Then I look at the medial meniscus. Again, it's showing some hyperintense signal, but that hyperintense signal does not reach the articular surface. You can see here, this is not a tear because it does not reach the articular surface. But what I do see is a lot of marrow edema here medially. So I'll look at the medial collateral ligament carefully on other sequences. And also what I see is, you can see this here. This is the posterior capsule, this here. And you have edema out there. So I'm suspecting some posterolateral capsular injury also. So now I'll look at the corneal images to try to look for MCL, and I'll try to look for posterolateral corner. So here again, there is hyperintense signal in the meniscus, but it's not reaching articular surface. So it's not there. There's some marrow edema here in the peripheral posterior lateral tibial plateau also. You can see the fibular collateral ligament is intact. You can see the popliteus tendon is intact. Now we look at the medial collateral ligament. You can see a lot of subcutaneous edema, but can you see this medial collateral ligament looks continuous here? But as you go posteriorly, you can see this, there is a breach here. This section here, I hope the arrow is seen. Yeah. Here. So now I look at it on the axial images. As I come axial, this is the MCL. So the posterior fibers, you can see posterior fibers of the MCL, and behind that, what do we have? We have the posterior oblique ligament, or which is nothing but the posterior medial capsule, which is thicker. So you have a high-grade injury at femoral attachment of posterior fibers of MCL and the posterior oblique ligament behind it. So this is a posterior medial corner injury. Plus, we were looking at the lateral capsule, and we saw at this particular section, there is a lateral capsular injury. See how this black line is seen well here, but at this section, it's not seen well. So there is posteromedial and posterolateral corner injury. But remember, on MR, this edema exacerbates things, like we overestimate things in acute conditions. So you have to correlate MR finding and the clinical examination. But the thing here important is for you to make sure that you are checking for the posteromedial and the posterolateral corner structures too. So here the findings are moderate to marked anterior tibial and moderate peripheral medial femoral marrow edema. Impactional, you have high-grade mid-substance posterior cruciate ligament tear. You have a low-grade anterior cruciate ligament injury or sprain. High-grade posterior fibers femoral attachment, medial collateral ligament, and posterior oblique ligament injury, which comes under posterior medial corner injury. And also you have a low to intermediate grade posterolateral capsular injury, what you can see here. And invariably, whenever you have all these injuries, make sure that you are looking at the nerve, because very often common peroneal nerve can be injured when there are multi-ligament injury. Yeah, so we don't have any of those. This is the pes answerine tendons, and you can see around that you have some fluid. This is the popliteus muscle, which shows edema. Yeah. Inflamed synovium example. Okay, so let me see if the next case has it. If not, I'll just show in my presentation. ACL bundles. Yes, sure. Let's try to look in. Let's look in the previous case, I think. Yeah. In this, because the ACL is not normal, I'll not be able to show you. Sure, let's look at the previous case. Give me a minute. Yeah. Let's look at the previous case because the ACL was normal there. Yeah. So as we all know, ACL has a anteromedial and a posterolateral bundle. Remember, sagittal images look good to try to see the ACL, and we all tend to look at that first. But you can have, see, this is the normal PCL here. You can have volume averaging while we just wait for this to open. Yeah, okay, this is just opening in a minute. Okay, yeah, this is a good place to show this. Yeah, so those sagittal images look good, but remember, you don't always see the ACL like this. You can have some averaging with the adjoining lateral femoral condyle. So if I show you the axial image here, see how closely the femoral attachment is related to the femoral condyle. So the section may little include both of them, and you may see some bright signal and think, oh, is this a tear? But it's not a tear. So here, if you look at it, you can see it's parallel. So sagittal images, you look for continuity, you look for parallel to the Blumen-Sachs line. This is the Blumen-Sachs line going here along the femoral intercondylar roof. But also, if you see towards the tibial attachment, it has some striated appearance, which is normal. So this is the anteromedial bundle. This is the posterolateral bundle on the sagittal image. Let's look at it on the axial image. So if you see here, when you see carefully, you can see here, they are together. This is anteromedial, and this is posterolateral, and this is anteromedial. But when you come inferiorly, you can see them separating out. Now you can see anteromedial and posterolateral. At this section, they are so together that you will not be able to see separately, but here you can see anteromedial and posterolateral bundles separate. Let's try looking at it on the corneal images too. How do I see it? Yeah. So towards the femoral attachment, they are so closely placed that it can be difficult to differentiate. But as you come here, you can clearly see two bundles. This is anteromedial and this is posterolateral. Okay, so we can move to the next case, and then inflamed synovium. Let me just try to show it in one of my lectures. Yeah, because I'm just, that's why I got all the lectures so that we can. Let's go to the last case. Okay. So while this is just opening, okay. So we start looking at this sequence, and the very first thing I see is marrow edema out here in the anterior lateral femoral condyle. as well as in the posterior lateral tibial plateau. So that's straight off the bat, that's telling me that I need to look for the ACL. There is something probably wrong with this ACL in this patient with this marrow edema in this typical pattern. Same thing, I look here. Okay, so this here is the sulcus terminalis. There's little depression there, but this paroedema pattern is getting me worried about ACL. Okay, so this patient has undergone an ACL reconstruction and now has come back with injury. And what do I see? 1 second, let us just, let it just load completely. Yeah. So you can see here, there is a high grade ACL tear in its mid portion. This is the femoral tunnel attachment. This is the tibial tunnel portion. But then here in the center, there is tear. Now, what are these fibers out here? So that's something, is this an anterior intercondylar nodule? No, because remember, if a stump sparing surgery has been done and some part of the stump has been left behind for its function of proprioceptive fibers, that can look like this. And anyway, this patient, the patient has come back. So history again is important. Patient has come back with injury. This is what I said when I said there will be Hoffa's fat pad, some scarring in this area, which is expected. And now, also what I see here is, can you see this cartilage defect? So when you have marrow edema, look carefully at the overlying cartilage. There could be, and now we look at it on the corneal images as it is just loading. So this patient has an injury here, impaction injury at the anterior lateral femoral condyle sulcus terminalis. Also, if you can see, there is an ACL tear that we already spoke. The graft has torn, high grade injury. Again, high grade, I don't see many fibers intact, only few fibers are intact. And also I look at the cartilage. This is just loading a bit. Yes. So now can you see this cartilage defect out here very well? So remember, we look at cartilage carefully and the same section here. Yeah, you can see this cartilage out here. So whenever you have marrow edema, look at the overlying cartilage. Here there's a full thickness cartilage defect. And this looks like a acute cartilage defect because there's underlying marrow edema and it's very sharply marginated. The older chronic ones are usually more wider and not so sharply marginated. We look at the meniscus, and again, this is, look at this lateral meniscus. This is normal medial meniscus. This is lateral meniscus, and you're wondering, is this a tear out here? So what do we look at? The lateral meniscus, we come back here. Can you see this lateral meniscus posterior horn looks smaller than the anterior horn here? You will all agree. But this section where on corneal images, I was worried, can this be a tear? This bit here. When I look at it on these images, it's not bright like fluid. So that tells me this is likely only a post-operative change. So to distinguish between a meniscus where a partial meniscectomy has been done or if a repair has been done, you can have abnormal shape of the meniscus, obviously. You may see some bright signal or defect, but remember, if its fluid intensity looks like this, if it's not fluid intensity, if there is no displaced flap, it is just post-operative change. Again, this effusion is just because of the trauma. How does thickened synovium look? Yeah, I can show that here. So this here, there is some little bit of synovial thickening, though not too much. I'll show you a case where there is more. This is the plica that you may see. As I said, we see it often, and that may not be symptomatic. So in this patient, there is mild lateral femorotibial translational marrow edema pattern, high-grade mid-substance ACL graft injury. There is a full thickness cartilage defect. We give measurement. So something maybe about 3 millimeter transverse and 5 millimeter AP, full thickness, central weight-bearing medial femoral chondral defect with moderate underlying marrow edema. PCL is intact. Medial collateral ligament is intact. This is the fibular collateral ligament, which is intact. And this lateral meniscus. So obviously we'll find out the history, and this would be post-operative changes. It doesn't look like a re-tear. Okay. Ramp tear lateral meniscus. So we usually don't use the term ramp tear we use it for medial meniscus, because what happens is lateral meniscus, since there is popliteomeniscal fascicles, which I'll show you, you can see that they can be torn sometimes, but they are thin structures. So we usually use the term ramp for medial meniscus in our reports. I'll just show you both of those. How do we recognize natural ACL versus post-op graft ACL? Okay, we'll look at that also. Depth, width, and length of a song. Okay, you're studying the results of oats and tunnel positions. Okay. TB, knee, early and late. Okay. So let's look at the ACL ones here. So looking for single bundle tears, non-fat sat sequence, axial images, if you trace them, they always help. Trace it on all the sequences. On this case, let's discuss the tunnel position and natural versus post-op ACL. Okay, give me a minute. Let me share the screen. Yeah. So now tunnel position is something what we do, what we look at. But the caveat being that you may have a normal graft, even though the tunnel position is abnormal and the patient may be asymptomatic. But what are the things we look at? Yes. 1 second. I'm so sorry. Okay. Let me show where the line. Okay, this is the line. So this here is the Blumensaatz line, okay, along the posterior intercondylar roof. Maybe I can angle this a little bit here and angle this a little bit here. Yeah. So when you draw a line through the Blumensaatz line, the tibial tunnel should lie posterior. So this, I think, is just very minimally anterior. So the tibial tunnel should lie posterior to the Blumensaatz line. It should not be too posterior. So it should be somewhere in the mid of the tibia. If I look at the femoral tunnel, how do I make out whether it is fine or not? This is where the femoral tunnel is just about coming out. I draw a line along the posterior femoral cortex. So the femoral tunnel should lie posterior to it. If femoral tunnel lies anterior to it, that is not normal. And based on that, you may have a more vertically oriented ACL or a more horizontally oriented ACL. On the corneal images, you should have the ACL tunnels at between 1 and 2 o'clock here, and somewhere between around 7 o'clock on this side. Oh, sorry, 1 and 2 o'clock this side, or depending on the knee, this would be around 11 o'clock. And this way it would be somewhere around 5 o'clock on the corneal images. That is how we look for the normal position. How do we make out ACL post repair or not? So we look at the femoral tunnel. You can see the femoral tunnel, you can see the tibial tunnel. So you know that this is post ACL recon. And what was the other question? How do we measure the dimensions? So when I measure cartilage pathologies, we always measure the maximum AP as well as the transverse dimension for femorotibial cartilage. For patellofemoral, we give the craniocaudal as well as the transverse dimension. Spontaneous osteonecrosis of knee is not a term that we use now. We use subchondral insufficiency fracture, because we know that what was earlier called as spontaneous osteonecrosis is the subchondral insufficiency fracture. Not all of them go into SONC with conservative management itself. We call it osteonecrosis only when there is a clear area of avascular necrosis. Otherwise, we don't use that term. Yeah. And thickness wise, we mention more than 50% thickness, less than 50% thickness, or just surface fissuring. So you can use that outer bridge classification or just give the description. Okay. We have questions for TB, okay, TB. So let me just try, give me just a minute. That's why I kept my lectures ready to show you. Okay, 1 second. So I can show you. Yeah, I'm just opening this slide and showing you. Yeah, I'll just share this. Yeah, yeah. So I hope this is visible here. Yeah. So this is how synovial thickening looks. So if you realize normal fluid, what the cases you saw looked very bright. But here, can you see this intermediate signal intensity? So this is diffuse synovial thickening. And here, notice how that is extending into the inferior patella. And just to show an example of, can you see the synovial thickening again here? It's not just fluid. So if you give contrast, you can see this enhancing. Yeah, this is a good example again. This is not just the joint, this is fluid. You can see this is fluid, but around it, this hyperintense thickening here is synovium thickened. We have given contrast and you can see how it is enhancing. The fluid does not enhance. This is the joint fluid that does not take up contrast, but the inflamed thickened synovium takes up contrast. So this is typical tuberculosis. Yeah, so I think that is a good example. This is a very good example of synovial thickening. This is synovial thickening. Even without contrast, you can make out this fluid is not clear and this synovium is thickened. But with contrast, you can show it better that this is thickened and it is enhancing. There is erosion out here. There's marrow edema changes out there. Any other? Let me just see. Yeah, again, if you look at this, this is not like clear fluid. There is within it debris, within it material. So that is infected. Okay, then I think the question was on cartogram or T2 mapping. So T2 mapping, frankly, looks good, but in reality, we use it in only few situations. See, when there is already diffuse cartilage loss and all of that, doing a cartilage mapping is not really going to help much. We can see it morphologically. It's only when the cartilage thickness and signal intensity both are normal. Say if your routine images are showing cartilage softening by showing it bright, that again means grade 1 chondromalacia. It's already softened. But if on routine images it looks normal and you want to look, so the place where we use it practically is when somebody is planning something for a focal cartilage lesion, for example, maybe microfracture or Oates procedure, whatever it may be, and they want to evaluate the adjoining cartilage, which is looking fine on the normal MRI, on the routine MRI, but you want to see whether it is already degenerated or not. Other than that, diffuse OA and all of that, I don't think it really helps because you can already see the cartilage findings well on this. The principle being that in normal cartilage, collagen fibers are nicely and evenly packed. So there is not much place for the water molecules to move around relatively. But when the cartilage degenerates, these collagen fibers which are there, instead of being nicely arranged, they get all disturbed, and there is all space between them where the water molecules start moving. This leads to increase in the T2 relaxation time. That's what we call it. T2 relaxation time increases. Now, is there an absolute value above which it is normal and below which it is abnormal? No, doesn't work like that, because there are so many articles which give different values. And I don't think we've studied in our population what's the normal T2 relaxation time. So what we do instead is we look at the overall knee, compare it with the adjoining structure. You look at the cartilage in that knee. So that's why I said when the whole cartilage is already degenerated and thinned out, I don't think it really helps at all. In post-TKR, can we evaluate MCL, LCL, and quadriceps tendon? Yes, very well. So we can, in TKR, so in fact, we do MRI in TKR all the time. How much artifact is there depends on the material of the implant, but most of the times we can use certain sequences. Okay, certain examples. Maybe I can just quickly share an image. I hope there is time. Yeah, give me just a minute. I have this lecture also. So I just carried my entire lecture thing so that we can give me just a minute. We have the TKR lecture too. Yes. TKR. Yeah, okay. MRI, TKR. I'll just share the screen again. Yeah, so just if I can show you the image, this whole thing becomes a whole complete separate lecture, but let me just show you. Yes. So by using the right sequences and by using these artifacts, so you have certain metal artifact reduction protocol. So this is without it, where you have so much of artifact, and this is by using those. So vendors have it, and we have it on our machines. If your machine has it, you can always use it to get images like this. There will be some artifact, but it can be reduced significantly. And as I said, you can see it so well, all structures. You can see the patellar tendon, the quadriceps tendon very well. You can see any osteolysis area as well. Let me show you example directly. Give me just a minute. I'm sorry. Yeah. So extensor mechanisms. You can see this quadriceps tendon tear out here, but this can also be shown with ultrasound, the extensor mechanism. To be frank, superficial structures can also be shown with ultrasound. Here again, this patient, you can see the entire quadriceps tendon, there's a tear and this patella is dislocated, is displaced inferiorly. Here there is patellar avulsion. Patellar tendon has come down and there's this gap here. And one second, let me show you the MCL. So you can see here. This is the MCL, tibial attachment, and you can see at the femoral attachment, there's a tear. Here there's a retinaculum defect. Here there's MCL laxity, and towards the tibial attachment, there was a tear. So you can use these sequences. So two things. One is either you have a 1.5 Tesla machine, because higher the strength of the magnet, more is the artifact. So either you use a 1.5 Tesla machine, increase the receiver bandwidth and do a scan, or you use a 3 Tesla machine, but then you need the MARS protocol, the metal artifact reduction sequences that we have. So we do this regularly. Any contraindication for MRI and TKR? Not exactly. So even immediately after the surgery and all, we have done the scans, there's been no problem. But with 3 Tesla, with a higher strength, magnetic field strength, there's just a theoretical possibility of some kind of heating in that location. Very frankly, we've not come across it, but we do instruct the patients that if they feel any kind of heating sensation, they should inform us. But not a problem. I won't, a contraindication only if the patient has a pacemaker, yes. So cardiac pacemaker, cochlear implants, absolute no for any kind of MRI. But the implant itself, no contraindication. Okay, so I think that answers all the questions. Any other questions? Staples immediate post TKR, no issues, no problem at all. So in fact, earlier it was thought that things like stents, vascular stents. You have to wait for 6 weeks for it to get endothelialized. But now we know that no, nothing happens. It doesn't move out. Similarly, any kind of staples, there is no issue. But none of the external fixators, no, we cannot. External fixators, any kind of electronic device like artificial pacemaker in the heart, Holter monitor, so any of those you cannot. But internal fixed orthopedic implant, there is no contraindication. But how much artifact it causes depends on the material of that implant. So, for example, ACL, we don't need to use any particular extra sequence. Regular sequences help. But sometimes we have this old ACL and there is so much artifact due to whatever material was used that time, many, many years back, that you can't see anything well in just that area. Adjoining areas you can see, but that particular area you may not see it well. So then we use a combination of CT and MR. Steel, there is no problem, completely safe. So there are two things. One is MR safe and one is MR compatible. Titanium is MR safe as well as compatible, so it will not affect the image also. Not only will there be no harmful effect to the patient, but that image also there will be no artifacts. It will look good. But there are things which are MR safe but not compatible. So images will still show artifact, but the patient will not have any harmful effect. It's not as if it's going to come flying out or anything. No, that doesn't happen. Early infection in TKR, if it's very early, it's a problem on imaging because post-op changes. You can have some joint effusion, you can have some marrow edema. That can be a problem.
Still is studying. Still is attending a lecture.
So very early infection is very difficult on MR. You have to take the lab findings.
For boy like you. See.
Okay, so I think that completes all the questions. It's really been a pleasure being a part of this, and I do thank Dr. Neeraj Bijlani, OrthoTV, for letting us be a part of it. And any one of you want to reach us, you can always reach us at www.innovisionimaging.com. We have online courses, we have regular academic activities. We even have a way where you can send us any case for a second opinion, direct upload on that. Any of you, any centers who want to tie up with us for MSK imaging reporting, all of that, you can visit the site and have a look at it. Thank you. Thank you. Good night.